Good afternoon, everybody. This is Mark Crockett. I'm going to start this webinar in just a minute. We have a lot of people who are still joining, so we're going to give them just 1 minute to join the conference here. So we'll begin very shortly. Wonderful. Well, this is fantastic. It's great to see so many people joining. We have a lot to cover today, so we're going to go ahead and get started. First of all, wanted to welcome everybody today to this APIC virtual symposium. We appreciate it for everybody coming today, taking time out of your busy schedules to come and help us understand 514 and beyond Legionellosis. My name is Mark Crockett, CEO of Phigenics. I'm a clinician by background. Today I have with me Alex Peregord, who is our product manager for validation testing, and Morgan Sagely, who is our product manager for water management programs. I want to thank APIC for hosting us today. It was a wonderful collaboration with this important organization, and we appreciate it. I wanted to remind everybody that we are a certified continuing education provider, and the audience can email us at webinars@phigenics.com for a certification of attendance. So appreciate that. Couple of housekeeping notes. I want to make sure everyone understands this program. The presentation will be recorded and distributed to all registrants. If you have any questions, please use the Q&A box found in the Zoom toolbar to submit that. And if you're having any technical difficulties at all, please use the chat box that's found also in your Zoom toolbar to message us, and one of our team members will reach out to provide support. So today we have a number of learning objectives. Number one, we want to be able to identify what the best practices are for incorporating additional waterborne pathogens into your current water management program to support alignment with broader infection prevention and control strategies. We want to describe how combining clinical and environmental risk characterization, proactive testing, and effective response frameworks can support a broader scope of pathogens. We want to assess ways that water management programs incorporating these pathogens that are beyond Legionella contribute to infection prevention, reporting, regulatory readiness, and broader risk mitigation strategies by enhancing organizational defensibility and continuity of care. Just briefly, we wanted to take a moment to acknowledge implicit bias and how that's affected the field of water management and how it contributes to health disparities, specifically in Legionella infection risk. Aging and complex plumbing systems are known to promote biofilm growth. They increase pathogen proliferation, and neglected water systems are more common in low-income communities. This disproportionately affects communities of color. Recognizing these biases is essential to reducing that impact. We have a number of studies to support that point of view, and we are happy to give those to you if you need to. So feel free to reach out to the team, and they'll send that information your way. So just to review briefly, our webinar series, Beyond Legionellosis, has focused on building the knowledge base consistent with growing awareness of waterborne pathogens and patient safety beyond just Legionella. In our first webinar, and again, all of these webinars are available, the recordings are all available. We looked at data from the CDC's MMWR report on waterborne disease outbreaks linked to drinking water. We explored how biofilm plays a major role in microbial hazards and discussed how current regulations are addressing these risks in the healthcare setting in particular. In our second webinar, we reviewed the newly published ASHRAE 514 standard and how it expands the list of considerations and what that means for water management teams that are looking to broaden the scope of their programs. Today, we're bringing it all together. We'll look at how teams can apply insights from both previous sessions to develop strong validation strategies and include a framework for robust environmental testing.
Thank you, Mark, for kicking things off for us today. My name is Morgan Sagely. I'm going to take us through some of the content from our first two webinars, just at a high level, to help frame up our discussions today. So starting off, that first webinar that Mark mentioned, we did dive into the CDC's MMWR report on surveillance of waterborne disease outbreaks associated with drinking water. And in that deep dive, we learned that each year in the US, waterborne pathogens cause an estimated 7.1 million illnesses, over 6,000 deaths, resulting in 3.3 billion in direct healthcare costs. Drinking water exposures are associated with 40% of hospitalizations and 50% of deaths, and are primarily linked with biofilm pathogens such as Legionella and NTM. Figure 3 from this report shows the number of outbreaks, not cases, associated with drinking water. And you can see midway down the x-axis here, you'll notice the largest number of outbreaks occurred in healthcare settings. And of those, nearly all were biofilm associated. These are the types of findings that reinforce what we see every day regarding this risk is not limited to municipal water supplies. This is within plumbing systems, which allow biofilm to grow. And comprehensive water management can help us break the chain of infection by maintaining disinfectant residuals, temperature control, and routine flushing. We're able to disrupt biofilm and premise plumbing, which is our reservoir, directly reducing the risk of exposure to high-risk patient populations, our susceptible hosts. In our second webinar, we built a little bit on what we learned in that report, the connection to biofilm, the growing regulations around pathogens beyond just Legionella. And we kind of dove into ASHRAE 514 and used that as our guide to take a deeper look at additional clinically significant microbial hazards. So I'll take a quick moment to revisit a few characteristics of that standard, ASHRAE 514, which we did cover more in depth in our second webinar. I think it's important to note, we know that 514 mandates the use of ASHRAE 188. So while the framework for managing building water system risks is very similar, the scope within those two standards has expanded greatly. ASHRAE 188 focused solely on Legionella, while 514 really broadened the lens to include additional microbial, chemical, and physical hazards.
Yeah, as we were building this slide, it occurred to me that, the reason for 514 and how it was built is largely because everybody who's on this call was so successful at managing Legionella utilizing the framework in 188. So we're being rewarded for our good work by getting more work, which is sometimes the result of really doing excellently. So could you remind us of the type of microbial hazards that are covered in the standard under 514, and how should clinicians consider or target, those pathogens of interest?
Yeah, absolutely. That's a great question. So I mentioned 514 really expands on the microbial hazards. You can see here we've got the 13 listed on the slide, and you'll notice that 4 of them are grouped together on the left-hand side here. And that's because in Appendix C3 of this standard, these 4 are noted as being most commonly associated with disease. Now, that's likely because the surveillance and clinical impact are increasing, which is something we did just see referenced in that CDC's MMWR report, also through NHSN data. And Mark, you asked about targeting certain pathogens and how would you go about doing that? Really, clinicians play a massive role in helping their water management teams decide which pathogens to prioritize. So you all are the experts when it comes to understanding the clinical context specific to your facilities in your patient populations. So maybe taking things into consideration like disease cases, regional trends, or additional emerging updates.
So thank you, Morgan, for providing that framework and driving focus on the additional microbial hazards presented in 514 is mostly what we're going to talk about today. As we examine these primary pathogens, what key characteristics should our infection preventionists be considering to build a meaningful profile of their epidemiological relevance to them, their relevance to them?
Sure. Let's start, with a really familiar microbe to water management. Legionella are really plumbing specialists. Ecologically, Legionella rarely thrive outside of the built environment, but building water temperatures with the pockets of water stagnation, disinfectant breakdown, and biofilm association supports its persistence as an exposure source through aerosolization and aspiration at those end-use points. Its at-risk population, is relatively broad with, moderately selective susceptibility that supports clinical diagnoses. But even amongst growing awareness for broader pathogens, Legionella continues to be the most reported and, is more easily ascribed back to the building water system, supporting data that reveals, a staggering annual disease burden. We see here that $2 billion annually. And epidemiologically, Legionella investigations aren't so much about whether water is implicated in the disease, but from which water source, sort of oftentimes being about determining whether it's coming from the community or healthcare environment. But from a regulatory standpoint, Legionella has been a primary driver in maturing the infrastructure of water management practice. And then kind of as we extend into non-tuberculosis mycobacteria or NTM, this expands some of the environmental transmission pathways to consider. So where inhalation is still of concern, infection via direct inoculation of the patient through contact with contaminated surfaces, and even ingestion become considerations. So this pathogen is more directly targeting your most at-risk populations, including those with structural lung disease, or those with compromised immune systems. So when you observe even the available body of case studies related to NTM outbreaks, what's kind of critical to note is that oftentimes the investigations cite both failures in IPC practice within the space and poor quality, poor water safety management in conjunction. So NTM infections have, high, complex, and longer-term treatment costs that often require months of multi-drug therapy and frequent recurrence, leading to numbers like this $1.7 billion figure that we see for 2014. From a water management standpoint, these are tricky microorganisms. They're characterized by the sort of waxy, lipid-rich cell walls that shield them from disinfectants and high heat. But that makes early detection and multifaceted control strategies in the environment critical as well. And then moving on to Pseudomonas, this is a highly versatile bacteria. In fact, it's one of the most prolific biofilm-forming pathogens that we tend to encounter in a healthcare setting. In the plumbing system, Pseudomonas, and especially Pseudomonas aeruginosa, is very effective at a process called quorum sensing, which works kind of like a concerted chemical communication system in developed biofilms. And under different environmental conditions of stress or nutrient availability, Pseudomonas can kind of work cooperatively and competitively with other microbes like Legionella, Stenotrophomonas, Burkholderia. It's becoming increasingly relevant in a clinical setting. You'll note this 2017 statistic: over 30,000 hospitalizations, thousands of mortalities, and over $750 million in attributable healthcare costs. It's a highly communicable pathogen, and from a clinical standpoint, its versatility lends itself to those intrinsic and acquired carbapenem resistance among some strains, particularly amongst that Pseudomonas aeruginosa. The challenge for Pseudomonas is in its ability to aerosolize via contaminated water, kind of persist on surfaces and spread easily, even when best practices in hand hygiene are followed.
Yeah, and I mean, I will never forget, in medical school, one of my first clinical cases where, we were showed a patient with a wound infection and, peeling back the bandages, and seeing the exudate and having the attending physician go and get a black light, and, show how this stuff just glows all over the place,
Mhm.
right? And that really, that last sentence that Alex was talking about is really important. At the time, the challenge was really, said you got to wash your hands, right? What we're seeing is really, as we've improved our hand washing and other clinical techniques of preventing infection, we're seeing more and more a lot of ways in which this stuff is coming from the environment and through contaminated water. It's becoming recognized as a much more important mechanism of transmission than it was when I was in medical school some time ago.
Yeah, thanks, Mark, for that insight. Now Acanthamoeba, this is an interesting pathogen because in its own right, it is pathogenic. It's most commonly associated with corneal infections and it's infectable through inhalation, aspiration, open wounds. But its primary significance actually is in its ability to play host and amplifier to Legionella. And to a lesser degree, NTM, which can persist intracellularly as well, but as a protective mechanism more so. Um, Acanthamoeba in the environment kind of operates similarly to the alveolar macrophage of the human lung. So Legionella prefer to infect and amplify within this protozoan host in particular. And its presence can also be an indicator of potential biofilm. So, we've seen some studies show 30 to 70% of Acanthamoeba isolates from building water contain Legionella, and 80 to 90% are biofilm associated from other literature sources. So for that reason, Acanthamoeba's primary relevance is in its ability to signal the potential presence of additional risk factors for Legionella, and point to the potential presence of mature biofilms and associated pathogens of concern.
So as we bridge this conversation into a discussion about holistic validation strategy, you've mentioned biofilms and even some of the supportive dynamics amongst these microbes. Would you be able to expand on their relevance within the building plumbing system?
Yeah. So biofilms are just complex communities of microorganisms. They have their own unique characteristics and life cycles. They can adhere to plumbing surfaces and use points at fixtures as a sticky extracellular matrix that grow and then as part of their natural life cycle and even water system disturbance, think local construction, municipal supply disruptions, can spread throughout the building water system and actually increase pathogen retention about tenfold. So these can create environments that sort of protect pathogens and support their growth. And typically they can double in size, in 24 to 72 hours. So looking at our primary pathogens of interest that we've been chatting about, Pseudomonas can support, rapid growth of this extracellular matrix. NTM is a strong biofilm builder in its own right, and it can embed itself pretty deeply within the biofilm matrix. And as biofilms mature, protozoa, kind of like those Acanthamoeba we mentioned, come to graze on the biofilm, supporting the enrichment of protected species, and as a preferred pathway for Legionella amplification. So each of these organisms has developed unique premise plumbing survival pathways and their own ecological niches.
And it really would seem that this is one of the key differences between trying to prevent water borne illness is that, this problem is ongoing. And if you're not vigilant about the water supply, and how you measure, monitor, and test, you can really it's just a constant threat that you have to continue with. And the problem is never something that you can count yourself as being done addressing. In that way, it's a little bit like food safety or other areas where the threat is ever present, and therefore the work is ongoing. So now that we have an understanding of the microbial hazards, we'll move our discussion more onto validation strategies and how a team might develop their approach based on a wider range of pathogens outside of Legionella and consistent with the direction 514 is going. Morgan?
Yeah, so the validation framework, there's a lot to cover here when we talk about validation, particularly building a defensible validation strategy. I think a really good place to start here is to just come back to the definition, right? The term validation comes directly from ASHRAE 188. And I'm going to read the definition here. It's defined as initial and ongoing confirmation that the program, when implemented as designed, controls hazardous conditions in the building water system. So in other words, validation is confirmation that the program, when implemented, is working. Now, there are no universal regulatory requirements for environmental testing, with the exception of the VA Directive 1061. But we see many guidelines recommending routine environmental testing as a supplement to clinical surveillance, right? That's called out in 514. In some cases, just clinical surveillance alone. But I do think it's important to note that testing alone, especially one-off testing events, is not a validation strategy. Validation is a function of a water management program. And that's why you're going to hear us strongly encouraging teams who want to do some sort of water testing to ensure that they have a water management program in place. And the reason for that is it allows you to focus on the right hazards. Okay, we've mentioned 4 microbial hazards today. So it's important to use clinical data to determine if you're focusing on the right hazards. It allows you to take into consideration facility-specific environmental risk factors, which help us understand where and why we should be testing. Water management programs allow us to use data to trend so that we can troubleshoot and adjust our controls if necessary. So it's important to have that continual data stream instead of just a one snapshot in time from one testing event. And then most importantly, a program really ensures defensibility, right? So if we're testing, we're likely to get some positive results. So in our program, we should have clear remediation responses outlined as well.
So what I'm hearing you say is that a program creates structure and defines the need for and justification around the testing.
Yes, it's a program really formalizes testing. Again, so we hear teams say, I want to do some testing, but a water management program is what allows you to formalize testing as a strategy so that it becomes a true validation strategy, right? And it ensures that you can deliver meaningful insights to protect patient populations. It's going to allow you to strengthen regulatory compliance. And then again, that importance of defensibility. It will provide defensible data to prove that this program that you've built and implemented actually works. I think we're going to pause here now. We do have a couple of questions for the attendees today, so those will begin popping up on your screen. And the purpose of this is to just get you all thinking about the difference in testing and validation and just enter some info on how your own facilities have historically approached environmental testing. So we've kind of looked at the difference between testing outside of a W&P and then implementing a validation strategy. But I know that's why you all joined today, right? To get a little bit more of an understanding. So we're going to continue that conversation. We're going to look at what components actually make up a holistic validation framework. So Alex, if you don't mind, will you talk us through what those components are and how our attendees can take this today and go apply it within their own water management teams?
Yeah, thanks, Morgan. So at face value, we can pair a validation strategy kind of into 4 key components. That is sort of selecting a method for confirming pathogen presence, and perhaps more importantly, kind of developing a strategic plan using facility-specific information and patient profiling to target key locations at defined frequencies. And then 4th is having a set of defined response and remediation protocols in place. So contextually, the validation strategy really must address water management program performance and inform next steps. So that is based on the water profile received into the building. How well is the program controlling amplification and subsequently mitigating the risk of exposure to patients' potential points of transmission?
So what are some considerations for healthcare organizations when evaluating test methodology in particular?
Yeah, thanks, Mark. So ASHRAE Standard 1 or 514 does provide some informative guidance or general considerations for testing. It includes references to the standard methods for culturing and microscopy, and even some qPCR methods. It's careful to note that these are just examples only, so it does leave much of the decisioning up to water management teams. When evaluating a method, it's really important to consider how the use or pairing of multiple methods best fits a facility's needs, and/or an organization's strategic long-term goals. On a really basic level, asking questions like, does this method distinguish between living and dead organisms? For a particular pathogen, can the method detect species of clinical relevance to your facility? I did note a question in the chat, about Pseudomonas, more broadly. There are 200 species of Pseudomonas, but Pseudomonas aeruginosa is of particular clinical relevance. And that's an important, question to ask of your test methodology. Can it distinguish aeruginosa from the broader species? If not, does the lab, that you're evaluating offer options for speciation? And then the other piece to this, and I think deserving of some focus here, is that once you do start environmental testing, the data is going to accumulate. So keeping a secure and centralized record of your results is both a strategic practice from a data insights perspective and a defensible one from a data management standpoint. So in terms of insights, these pathogens won't be characterized from a single snapshot, but from trending and integrating results data into your ongoing program leading indicator data. So PM frequencies, disinfectant levels, temperatures. From a management perspective, validation data needs to hold up to scrutiny both internally and externally. So we do encourage the use of really robust and integrative data management infrastructure for communicating and storing results, response activity, retesting, team decisions. And then lastly, we just have a note in here on the evaluation of novel methods. As the demand for environmental diagnostics for broader pathogens rises, so too will the availability of innovative or novel methods to sort of circumvent some of the challenges presented by the standard methods. So water management teams are going to rely on the clinical expertise of their IPs here in evaluating the need for those novel methods, which might include, the detection of VBNC or viable but not culturable organisms that are still capable of causing injury, the advancements in turnaround time, and even multiplex PCR screening. But in evaluating novel methods, it's important to consider whether, they've been validated against the standard method, if they've been validated by third-party labs. The CDC gives pretty good guidance for Legionella on evaluating novel methods, and we would suggest using the same framework for broader pathogens. But that said, method selection is just one component of validation. As Morgan noted earlier, choosing where and how often to validate should really be driven by clinical and environmental risk characterization. So Mark, I'm wondering if you could share some of your perspective on the clinical considerations.
So absolutely. When you're thinking about where to test and how to test for a given pathogen, and we're already seeing some of the questions pop up about this, how often you do it. We want to make sure that the risk factors associated with facility and pathogen-specific patient profiles are front and center. This group of people uniquely knows this, right? Correct characterization of these risk profiles are driven by the expertise and leadership of IPAC stakeholders. They provide guidance from clinical surveillance, so facility-specific and public health data, They're evaluating patient susceptibility, and it's axiomatic that an area that's doing bone marrow transplant or some a neonatal intensive care unit are going to have a different risk profile from an outpatient pediatrics area. And characterizing that clinical relevance has to take all that into effect. And it changes, right? We know that, given, what's going on in the world, hospitals in particular will use different areas for different things. And so, having continuous visibility into the different areas of the water management program and how the facilities and the clinical dynamics are changing is absolutely critical. It really requires a continuous process of evaluation of not just the results of the water management program, but making sure that the water management program remains relevant. I think that's the best way I would be able to say that.
Thanks, Mark. Yeah, pathogen-specific patient risk profiling is critical and can subsequently then be aligned with an evaluation of environmental factors when designing your validation strategy. So the next step in this process involves sort of an assessment of the hazardous conditions in the built environment. So that would include identification of areas with high water age, temperatures optimal for pathogen growth, water chemistry characteristics. This is going to become increasingly important, the broader pathogens, and disinfectant profiling. And then sort of consideration for the quality and interactions, various plumbing materials and piping configurations. And then sort of additionally, consideration for those pathogen-specific modes of transmission we kind of touched upon before, aerosolization, physical contact, ingestion, via those available exposure pathways, meaning mapping of our most critical end-use points and fixtures where patients may come in contact with contaminated water. So think OR scrub sinks, Pseudomonas aeruginosa, or ice machines that may harbor NTM. Even looking back at the MMWR report, premise plumbing or point of use was the most cited contributing factor type for all biofilm-associated pathogen outbreaks. So being linked to 73% of individual contributing factors. So, pairing environmental and clinical risk considerations, we see a clear path forward emerging sort of guide programs and their validation strategies using a process that enables an evaluation of risk through the lens of severity and likelihood. And Morgan's going to walk us through how those considerations can support prioritization of water management performance confirmation in the healthcare environment.
Yeah, thanks, Alex. So Mark and Alex both walked us through those considerations for clinical risk and then those considerations for environmental. So we want to just walk through an example of how you can put those two together and actually apply this practice within your own water management programs. So what you're looking at on the screen here is a risk characterization matrix. You might have something similar in your own water management program. But really, this is a tool that's meant to help teams assess clinical risk and environmental considerations specific to their facility. So that once completed, you have a matrix that can help drive the prioritization of patient safety. I do want to note this is for example purposes only. We do recommend referencing your own ICRA or even the CDC's water infection control risk assessment for healthcare settings when performing the clinical risk assessment for your facility. In our example today, though, we're going to look at how a team might evaluate clinical and environmental risk when comparing different pathogens that have similar and differing modes of transmission. So first, we're going to walk through this assessment of a few patient areas when considering the hazard Legionella, which is shown here in blue. So let's assume that a water management team determined the patient population in the ICU falls into the highest clinical risk category. And the environmental considerations were also determined to be highest risk due to various modes of exposure that occur through the fixtures present in that unit. Because of that, we would see our ICU fall to the highest risk corner of our matrix. The emergency department, you can see, was placed in the high-risk clinical category, and the environmental risk, again, was determined highest due to the potential of aerosolization exposure, maybe from a decontamination shower. The OR, which you can see was still in the high-risk clinical category, but the environmental risk was determined as medium. Again, by considering those environmental considerations of patients' exposure to the hazard through aerosolized water droplets. So you could see how if you only had a water management program through the lens of Legionella prevention, once this was completed for the entire facility, you'd be able to prioritize where you may want to test at the distal point based on your highest risk patient population and their exposure to the hazard in the water system. We'll go to the next slide and you will see this same exercise for the hazard Pseudomonas shown through those orange tiles. Now, the clinical risk assessment stays the exact same, right? Since that's based on the evaluation of the patient populations. It's the environmental considerations that are driving some of these units maybe into a different risk category. However, the ICU is an example where we see no change, right? Based on environmental considerations such as direct contact with contaminated water or surfaces, plus, again, that exposure to water through various fixtures present in the unit. We saw the operating room actually move up on this matrix, right? Based on the consideration of exposure through direct contact, such as contaminated surface or even sterile equipment. And then we saw the emergency department move down based on overall less exposure to water in this area. And again, I hope you can see, I know we only looked at 3 patient units here, but if you had this tool completely filled out, this would provide a comprehensive view of where to focus either monitoring activities or environmental testing to ensure that your resources are directed where they can have the greatest impact on patient safety.
So thank you, Morgan. Morgan walked us through an effective environmental how an effective environmental testing strategy begins with robust risk assessment, and it's guided by the need to know critical questions about building water systems, building water system control, and clinical risk. So how do we apply these principles back to the validation strategy?
Yeah. So sample locations and location-specific sampling frequencies should be chosen kind of to paint the best possible picture of system performance after a full mapping of the water system and facility characteristics. So a well-structured water management program, should model that chain of infection framework with a focus on identifying those key intervention points that will help disrupt transmission pathways. Subsequently, the sampling plan should be designed, not just to collect data, but to illuminate system vulnerabilities and inform decisive action. It should be designed to answer, from a location perspective, is the bacterial load of the pathogen, what is that from my supply water? Within and across my building water system, how well are the established program controls demonstrably mitigating growth? And then how effective are exposure mitigation strategies for our most vulnerable populations in key point of use locations? And then from a frequency of validation perspective, given the dynamic nature of waterborne pathogen activity in the built environment, we want to think about how stable is my system through time? How do seasonal changes impact my overall risk profile?
So a lot of organizations are doing at least some environmental testing now, but as they start implementing 514 and putting that environmental testing into part of their validation strategy, how should a water management team prepare themselves for positive results, and how do you clarify routine environmental positives from clinical positives?
Yeah, holistically, that preparation piece is critical. As we mentioned, over the course of this discussion, when it comes to utilizing environmental diagnostics, context does matter. Often when teams approach us for environmental testing of pathogens beyond Legionella, they're already seeing disease in the environment. And often as part of investigation of potential water sources, we'll sample and areas clinical surveillance has noted clusters of infection. But diagnostic results within that context, have to make consideration for the reporting requirements of their authority having jurisdictions, matching of clinical isolates with environmental ones, and that testing schema may persist until a formal closeout either rules out or implicates water as an exposure source. So, at that point, often teams are faced with, almost no data on the given pathogen's activity in the building water system and have to start etching out visibility by working backwards from the suspected transmission points. But within the framework of proactive environmental testing for program confirmation, teams can plan for positives kind of before they happen, sort of building response protocols with clear thresholds for action, using decision trees built from, infection prevention input to help determine best practices and response procedures. And to our point earlier in this conversation, many teams we work with have become experts in Legionella risk mitigation and remediation. And in incorporating new pathogens, we aren't reinventing the wheel on water management, but we are building on and expanding from those same principles. So data from environmental validation through time, helps to support proactive visibility. And it also accelerates that learning process as it pertains to pathogen control within your facility.
Okay, so to summarize, as organizations evolve and mature water management practices beyond Legionella, what are the key takeaways for healthcare professionals to consider when they're integrating additional pathogens into these strategies?
Yeah. We encourage our clinical stakeholders to evaluate the current scope of their water management program and the robustness of their validation strategy. Clinical stakeholders are so uniquely positioned to help define the scope of relevant pathogens and to establish a clear set of safety goals supported by that assessment of patient and environmental risk factors. This leads then to this integration of measurable, actionable water management principles within that validation framework and works to build visibility into hazard presence through data and subsequently resilience through the continuous improvement of risk mitigation infrastructure.
Now, this is a complex and evolving area, but the goal remains clear: protecting patients and staff through smarter, risk-informed water safety management programs. Are there any final thoughts as we close, Alex?
Yeah, this transition reflects a systems level evolution, from isolated interventions to more integrated frameworks where we believe infection preventionists play a critical role in guiding cross-functional teams with both historical context and that forward-looking vision. Broader pathogen awareness via publications like that MMWR report is evolving. Industry standards like ANSI ASHRAE 514 signal that shift, not just in tools at our disposal, but in strategy. So as we, interpret this in Phygenics really as a call to water management teams to position themselves to adapt and lead the evolving landscape of environmental safety. As water management programs mature among our own clients, we see next generation and seasoned IPAC professionals stepping into leadership roles and building on a decade of, institutional knowledge around Legionellosis risk mitigation developed since and really even before the publication of ANSI ASHRAE Standard 188 in 2015. Sort of as careers advance and roles expand, the call we see is pretty clear. It's, carry forward the frameworks, share the lessons, strengthen cross-functional partnerships. We believe that this change isn't just inevitable, but it is making healthcare environments safer.
Wonderful. And just briefly, we're going to go ahead and go into Q&A just a second. And we've had some wonderful questions come in, and I'll distribute those to the team here. and we'll get some answers to you live. But just briefly, our next webinar, Beyond Legionellosis, is treating biofilms. So, this ever-present threat, how do we, make an impact there? So on December 11th, 2025, we're going to go ahead and do another one of these, and we're going to get into the nitty-gritty of keeping these biofilms at bay. So unless there's anything else from the team, I think we'll go ahead and talk a little bit. We'll go into the Q&A session. One of the questions that came in already is, how does validation differ from testing performed as part of a suspected or confirmed HAI investigation, which is something that, again, the people on this call are very familiar with. Anybody? Let's see. Morgan, do you want to take that one?
I'm actually going to let Alex. I think we had some thoughts prepped on this going into today.
Okay.
Yeah, I know that we touched on this kind of briefly. I think it's an excellent and important question. And as I noted, we often encounter clients who are interested in testing their water systems as part of an investigative process. Really what we tend to find in those instances is, again, that, the strategies that they have to implement really have to take consideration for implicating the water against existing disease, more so than providing feedback into the sort of ongoing implementation strategy of their programs. So it is, a heightened environment in which to perform testing, but really the sort of validation strategy is supposed to harken back to program performance in particular. I hope that helps to answer the question.
Absolutely.
Yeah, and if I could add just one thing too, Mark, on this. I know we've mentioned a few things out of ASHRAE 514. There is a lot of informative appendices in that standard that have a lot of useful information. I think Alex hit on this. It's not just about what's required, but also just the supplemental information. And there's an appendix in there on specific to healthcare facilities, and it's Appendix G. So if you all have a copy of the standard, it's the Healthcare Facility Guidance Appendix. There is a section on microbial testing just in general. It's G9, and they do talk about, testing when there is a suspected or a confirmed case versus testing to, as Alex noted, to have knowledge of program confirmation, which would be considered a validation strategy.
That's very helpful. And, if you don't have a copy of it, I think we'd be happy to provide one. Or point you to where you can get one. So we'd be more than happy to. I agree. This is one situation in which the regulation itself and the publication has some really helpful information in it. I'll go to a couple of the questions that came in from the attendees. One of the first questions we had, which I think is really, really insightful, do you think that the healthcare setting is the highest contributor to waterborne outbreaks due to better surveillance than out in the community and residential? Absolutely, right? If you look for it, you will find it. But healthcare is full of patients that need to be protected, that have a variety of different chronic diseases and immune issues that put them at higher risk. And we do. Our organization does work outside of healthcare in areas like gaming and hospitality, et cetera, where there's also a lot of testing going on. But healthcare is where the patients are, and they're the ones who are most likely to get sick. So I don't disagree that is something that is absolutely true. When you look, you find it. We also had another question about Pseudomonas as opposed to Pseudomonas aeruginosa specifically, and testing strategies do vary in terms of their ability to pick that up. We addressed that briefly, but Alex, if you wanted to comment, I think you can address that one.
Yeah, and I think this is where having IPs with, strong ability basically to scrutinize test methodology is really important. I think when thinking about, a validation strategy and methodology selected, it is really helpful for teams to have the ability to sort of distinguish between the species of clinical interest from those more broadly. Pseudomonas aeruginosa is going to be of the most clinical relevance. If you're seeing Pseudomonas more broadly in your system, more broad species, it is important to kind of consider that you do have the conditions, available to you, or basically that the conditions in your building water system are supportive of Pseudomonas growth. So both can kind of be helpful insights to your building water system. Getting that species level distinction helps you understand the clinical relevance.
Practicing clinical medicine for more than 2 decades would puts you in a position with Pseudomonas where I don't know many clinicians who don't have a personal loathing of Pseudomonas aeruginosa specifically. I'm not sure I like any of them, to be blunt, but it is certainly an area where the testing strategy's got to be and validation strategy's got to be specific. We had a very interesting comment about in the UK. I'd encourage you guys to read that. It brings up a good point that certain kinds of plumbing fixtures create more risk than others. Without the testing, it's hard to know, if some of those things, if some of those areas are, the shower wands, the way the showers are constructed, et cetera, are actually causing more problem. You got to do the testing to know. And so, it's important. It's going to be an interesting area of development. So appreciate that question. One of the questions was, how do you measure water age? Now that's an area for our company, that we have devices and things that do some of that work. But Morgan, you have a little bit of a opinion on that, I would imagine.
Yeah, it's a great question. You heard mention of water age being a contributor to biofilm a couple times in today's presentation. It's also throughout numerous industry guidelines and standards. The CDC actually has an acronym STAR, which does outline, 4 ways to control Legionella growth within a building water system, and why we're doing that. And one of them, the A in that acronym, is water age. We're trying to reduce water age, turnover water, so that we can bring in water with adequate disinfectant levels. So to answer your question, how do we measure it? Something that we really recommend is understanding your disinfectant levels throughout your facility to understand if you have adequate coming in the building at that incoming main, but you have none in your cold water on the 6th floor. What is happening, between entry and your furthest distal point? Is there stagnant water? And so just measuring your residuals of your disinfectant can be a really good indicator of water age. We do recommend flushing in any stagnant or low use areas to help mitigate that, right? Because as we know, that's a huge contributor to water age as well. So I know Mark mentioned a few sensors, or, we do have a few ways that we can help reduce just the manual work that goes into having teams go in and flush certain rooms. And we're happy to share more about that. I also know our next webinar on treating biofilms will be a good opportunity to learn more about how water age contributes to biofilm presence and how we mitigate that through different ways.
Yeah, thank you. And I think that that's really important. Your organization may already have that in place. And if they don't, there are systems that basically measure the disinfectant level in real time and give you a dashboard of it. That's one of the things that our organization produces. A couple other questions that I know we have to be ending this here in just a minute. One of the things that was asked is, what would you recommend as a good suppression plan resource? We have the upcoming webinar. Again, but Morgan, maybe that's something you want to take briefly as well.
Yeah, and I'm assuming this is just in reference to, how do we help mitigate all of this, right? So
Mm.
that could be, I'm kind of understanding that question and how do we control it, right? But then also if we choose to validate and we find the presence of pathogens in the water system, how do we remediate that, right? So we are talking about two different things. Ongoing controls are part of just program implementation. And then sometimes our validation results indicate the presence of a pathogen in the water system. So then we move to a remediation strategy. Um, I mentioned the CDC STAR acronym. If you want, I highly recommend looking it up, referring to just reducing sediment, water age, measuring your disinfectant residuals, and monitoring temperature, making sure that your hot water returns not dipping too low into that prime target range for these microbial hazards to really thrive. But also, I mentioned 514, Appendix G, again, the healthcare facilities guidance appendix has a section on recommended remediation strategy if you are choosing to validate and you need help with resolving any positive results. And Mark, if I could, there's one question that I feel kind of ties to this that I see in the chat as well. And that was around um, sorry, I'm scrolling back to it. If we were testing for any of these pathogens, it says will be in the incoming potable water, and so will probably be positive. So what value does testing for these provide? And I wanted to answer this question. It's such a great question. We actually hear this from teams a lot. What if it's in the incoming water source? What can I do about it? And I think one thing I would say is we've actually seen at times teams come to us out of concern, right? They had a case, they wanted to test to confirm if water was a contributing factor, but we saw that they only performed testing at those distal locations, at your sink, shower, ice machine. We had no data to understand if the incoming water was positive or if it was non-detected. So this question of it's in the incoming, so what else can I do is such a good case for understanding why you build the framework out to be comprehensive. We have actually seen instances where it was not positive in the incoming water main. So
Yeah.
we knew something was happening between entry into the building and point of use at that ice machine. And it really helps you troubleshoot and problem solve when you understand point of entry all the way to distal point of use where your patients are interacting with water.
And supplemental disinfection injection into the potable water, if that's something that is, that is causing it, can also be something that's considered. A lot of facilities have that, particularly in areas where, there's endemic problems. There's one question, there's two questions that are, I think these will be the last two we'll take because we're going to run out of time here, guys. But we really appreciate everybody being here today. The question was, where does the risk characterization matrix come from? So the risk management area in your hospital, those folks would recognize this. This is sort of a standard tool that risk management uses. And so, if you're talking to folks who are in enterprise risk or compliance, they will use that kind of characterization matrix, not only for water and other things, but also for things like, compliance around, Joint Commission or any other type of risk for compliance that they have. So that's someplace where the risk management people, are familiar with it. That's where it comes from, and they're your friend on that. And then the second piece was, for that moved just a little bit. Give me just a second. So where is it now? Okay, so it says for facilities that do not yet have anything in place, any recommendations for how to show the expensive program will actually save them money and save lives. So there, again, the risk management people are familiar with the matrix. They can also be your friend on this. In the hospital, the risk management organization is used to seeing a number of different risks. This one is a little bit different because when you report a clinically relevant case to an organization externally as part of your public health reporting, any investigation on that is not protected necessarily by the quality management system, which is what leads to a lot of expense in dealing with these. And so our team is very familiar with that conversation and would be happy to help. But there I would say, a good relationship with your risk management folks in your organization can really help crystallize the value of this kind of approach to your organization in terms of how much cost risk and reputational risk you're eliminating by doing this job well. It's not just about, it's the right thing to do to protect the patients, particularly critically vulnerable patients. It's absolutely the right thing to do. It's also the right thing financially for the organization to do from a risk management, financial management, and a reputational risk point of view. So boy, I really want to thank everybody. We've come up on our hour. We had, over 800 people on this call. Really appreciate everybody's questions. There were a number of other questions that came in we didn't get a chance to address. We'll get some things out to everybody on that. Thank you for coming. Thank you to my team for their expertise, and we appreciate everybody coming. Everyone have a wonderful day, and do not hesitate to reach out for us in any way that we can help.